Good afternoon, everybody. My name is Terence Song. I'm a geriatrician based at University Malaya Medical Center, and it gives me great pleasure to welcome you to our uh, second webinar. What's really special about this particular webinar is because it's the first time the Malaysian Osteoporosis Society and the College of Physicians Malaysia have collaborated on a series of webinars specifically on bone health and osteoporosis. Um, if you've missed the first webinar and you would like to catch up on it or any of the College of Physicians webinars, they do have a YouTube channel, so feel free to go to YouTube and under the search bar, just look for College of Physicians Malaysia. The first webinar will be on there alongside all the other College of Physician webinars as well. Okay, so while we wait for other people to slowly join us, let me very quickly introduce to you our speaker today. Uh, so Gordon is a colleague and a friend who works at Queen Elizabeth Hospital in Kota Kinabalu, Sabah. I'm very proud that he's decided to serve in East Malaysia because knowing that most of my family is still there, I'm grateful that they are in good hands if ever they need it. So Gordon's a geriatrician based at QE. He's done some wonderful stuff there, but you are not here today to listen to me talk. I think you're here to listen to Gordon. So without further ado, Gordon, the virtual floor, the Zoom room is all yours.
Okay, thank you, Prof. Terence, for the kind introduction. Let me just try to share my slide. And very good afternoon to all of you, and welcome to the second special osteoporosis webinar, a collaboration between the College of Physicians and also Malaysian Society of Osteoporosis. I hope you can see my slide. Terence, can you?
Yes, can see.
Okay,
Perfect.
yeah. So today, so last week we had a great lecture from Prof. Shamila, who talks about the impact of osteoporosis and the epidemiology side of it. So today I'm going to bring you through fracture risk and bone health assessment. So without further ado, let me start. Let me minimize this. Okay. So a quick recap to the talk by Prof. Shamila. I hope some of you may have attended. So osteoporosis is very common. It's as prevalent as diabetes, but most of the time it's asymptomatic. Fortunately, the first symptoms that someone may experience from osteoporosis is a fracture, a fragility fractures. And among the fractures, hip fracture is probably the worst you can get, and it's associated with very high mobility and mortality. So we're talking about a mortality as high as 30% in a year, right? So that brings me to talk about today. Our topic, we will guide you through the diagnostic algorithm, and then we talk about risk stratification, and probably a snippet into these treatment treatment options. So hopefully that will set you up nicely for next week, week 3 of the webinar by Prof. Jaya, that will brings you through the treatment approach in osteoporosis. I will start off with 3 case sharing, a very simple case. The first 2 are actually husband and wife. So I believe these cases are kind of common probably in your daily setting as well. We have an 81 years old here, Mr. B, I call him Mr. B, who has moderate dementia due to Alzheimer's disease and visual impairment because of glaucoma and macular degeneration. He has high fall risk. In fact, he has fallen in the past, and he requires some assistance in his basic area. So he's moderately frail, as we classify him to be. So because of the height, I think he has a few risk factors here. His age, his fall risk, and his frailty. So I decided to screen for osteoporosis. So it turns out that his bone mineral density test, the T-score, we can see that in the left neck of femur is minus 2.6. And also did a FRAX assessment for him. The MOS is 10% and hip fracture is 5.9%. Okay, so something similar to how you have encountered before. If you are a treating physician, what would you do? Would you choose to treat? If you do, what will be the option of your treatment? You can keep this answer to yourself, yeah, for this three scenario, because at the end of it, of my talk, we are going to revisit this case scenario again, and then you may see whether your choice or your options are still the same. All right. So here, if you decide to start treatment, you usually will talk about oral bisphosphonate, or you can talk about some injectable here or anabolic. So which one would you choose? So this is the first patient. Second patient, his wife, yeah, so who came together with him to clinic to see me. And when she heard that I'm doing osteoporosis screening for the husband, she also said, I want the osteoporosis screening. So therefore, when I asked further of his past medical history, I noticed that she actually had a history of a Colles fracture just a few years ago. So actually, she has some risk factor too, although she is kind of robust for the age and no geriatric syndrome. So true enough, when we did a BMD, you can see that the BMD score here, the T-score of left hip is minus 3.4. All right, I did a FREX assessment again for her. MOF is 26%, hip is 14%. But she's less frail than her husband. Yeah, and she's very mobile, no history of fall. I mean, she had a fall 2020 when she tripped outdoor over a curb, yeah. But apart from that, she didn't have any fall. No issue with mobility. So in this patient, would you treat? And if you do, what would be your option? Same option I'm giving. Are you going to start the same thing as a husband or something different? So again, think about it and you can keep the answer to yourself. So at the end of the talk, we will revisit again. So now come to a third patient. So the first two patients, they didn't have any fracture in the past 2 years. Right? So the third patient is another 70 years old lady who is a British in origin, but married to a Malaysian for many, many years. So he's living in Malaysia with us. And she's educated, not frail. After retirement, she had a hobby, become an equestrian and horse owner. She fell and sustained a hip fracture on the right. You can see that from the X-ray here. Try to put some pointer on. Yeah, so I believe most of you can see that she has a right ankle femur fracture. So she was planned for a bipolar hemiarthroplasty, but initially the op was postponed because when she developed urinary retention with the urinary film showing leukocyte 1 plus, so the surgeon thinks she has UTI and decided to postpone the surgery. Of course, then we all know that those of us who manage hip fracture in the elderly, we know if we don't manage them in time, provide them surgical fixation, many of them go into adverse clinical outcomes, like reduce in function, increase in mortality. So we know that this kind of patient, we need to operate them within 48 hours. So we actually review the diagnosis. Eventually, we go through history, examination again, and we look into all the investigation. We decided that this is not a UTI. Even if it's a UTI, this patient can be operated within 48 hours. Yeah, so this patient successfully operated, long story short, and we provide rehabilitation that she is able to walk again. But we talk about secondary fracture prevention, but we need to treat her osteoporosis now and talk about adherence because so that you need to be compliant to the treatment in order to really see the BMD gain and reduction in the fracture risk. So in this patient, what do you think will be the option of your osteoporosis treatment? Is it going to be the same as the previous two patients? Or you're going to choose something different? So again, keep the answer to yourself. Yeah, okay, because after we have our 40 minutes talk, we'll come back and revisit the case again. So essentially, when we decide eventually what agents we want to use, number one, I think we go through this diagnostic algorithm. We have to come to a diagnosis of osteoporosis first. We then do a risk stratification by doing a fracture risk assessment. And then after that, taking into consideration the patient clinical profile, the pharmacology of the medicine available, and the cost resources, then we decide what agent to use. So if you want to look into osteoporosis guidelines, actually there are many. Yeah, actually I saw a literature that says that there's more than 100 osteoporosis guidelines, but perhaps I would like to just highlight a few that are commonly used worldwide. So we have the NOC National Osteoporosis Guideline Group in UK, and we have the ACE from US. ESCO is a European guideline, and last but not least, my personal favorite is probably the CBG of Malaysia, yeah, which is, I think we have one of the author here, Terence, with us today. So this is basically the summary of the Malaysian CPG. So what we do today is we talked about the risk factor last week, by Prof. Shamila. So those who are at risk, we will probably do a bone health assessment by either a BMD or FACS. So if the BMD is less than 2.5, let's say from the BMD effects, we determine they are either high risk or osteoporotic, we need to start treatment, it belongs here. But the problem is whether of any of these, actually, their features are very high risk. So this is something that we're going to bring you through later. Or some of these patients with risk factor, after you screen them, their T-score is actually not in the osteoporotic range yet. The T-score is better than -2.5. Or the FRAX is less than 20 of the MOF and less than 3 in the hip. So this is considered low-risk patient that we don't need to start treatment. So when we do our diagnosis, there are 3 ways we come to a diagnosis. We either do a DEXA scan to measure the bone mineral density, or we do a FRAX score, or we look for any hip or spine fracture before, because that is equivalent of osteoporosis. So for BMD, last week also Prof. Shamila mentioned about it. I believe most of you will know. So if you do a BMD, you have a T-score worse than -2.5, it is osteoporosis. Yeah, so that's the first way we can achieve the diagnosis of osteoporosis. Second way, that there are many centers in Malaysia that you do not have access to BMD machine. So it doesn't mean that you cannot diagnose and cannot treat as osteoporosis. You can actually do this FACS score assessment. This FACS score is actually created by the University of Sheffield many years ago. You actually can go to the website, FACS, and then you look for Malaysia. And there are 3 ethnicities, Bumi, Chinese, and Indian. So you can choose the appropriate one. And then you will input all these clinical parameters here, your age, the demographic, and also the risk factor. After which, the computer algorithm will measure the 10-year probability of fracture in major osteoporotic related fracture and a hip fracture. So for us to say this is high risk, or to actually make it an osteoporosis equivalent, so the 10-year risk of major osteoporotic fracture is more than 20%, and the hip fracture is more than 3%. So if any of these matches this figure, you can actually treat the osteoporosis. So this is the second way we can actually diagnose osteoporosis, by doing a FRAX assessment. But those of you who regularly do this FRAX assessment, you know that some of the risk factors are actually not accounted for in the original FRAX. For example, diabetes, fall risk, they are not actually adjusted in this calculation tool. So therefore, there's this expert group from the NOC group actually proposed some of this. Actually, we have to think about doing an adjusted FRAX score. The whole purpose of this is to make your FRAX score more accurate. So, for example, if you have someone taking medium to high dose of glucocorticoids, which is equivalent to more than 7.5 mg daily, then they advise you to add 15% to the score of MOF and 20% to the score of hip fracture. So what it means that if you calculate the FRAX score, and the FRAX score MOF is 20%, you add 15% to that. Means whatever score that comes out, 20 times 1.15, that would be adding 15%. And the hip fracture, you add 20% of it. And for those who has recurrent fall, meaning that they have 2 or more falls in the past 1 year, you actually add 30% to their MOF and also hip fracture risk. Okay? So for those who have diabetes, you actually enter yes in the rheumatoid arthritis column in the original FRAX. So this is for those who can actually good memory, and you want to make your FRAX assessment more accurate. So you probably want to refer to this summary table and see whether you need to make any adjustment to the FRAX score. But some of us, who don't want to remember so many things, you want life to be easier. Yes, you can. Actually, there's this thing called FRAX Plus, now recently available. So basically, this FRAX Plus is an adjusted FRAX calculation tool, taking into account in all the other risk factor that was not accounted for before. And this one, but the problem with this is you need to sign in an account. You need to sign up into an account, and then they provide you 5 credit for free. After that, each of the credit is going to be $1. But it makes your life easier. You can just key in everything according to what is requested, and then it will calculate an adjusted FRAX score for you, for your patient. So that is FRAX score. Yeah. So second way of determining osteoporosis is through FRAX assessment. So third is when the patient had history of hip fracture or asymptomatic spine fracture or vertebral fracture, you can also diagnose osteoporosis. So you don't actually need a BMD to come to a diagnosis of osteoporosis. So now after you have confirmed the patient has osteoporosis by either of the one of the three mechanisms just now, next step to do is to re-stratify them, whether they are classified into very high fracture risk, high fracture risk, or low fracture risk. So those who are BMD worse than minus 2.5 and the FRAX more than MOF 20, hip more than 3, so they are at least, they belong to this high fracture risk. So the non-osteoporotic one will go into low fracture risk. So now the question is, how do we identify which are the patients that belong to the very high fracture risk? So this is where I'm going to bring you through the next slide. So this American guideline brings us that these are the patients that will actually belong to the very high fracture risk group. So if you have a recent fracture within the past 12 months, if you remember the third patient of mine, Madam Susan, who had a hip fracture, so that patient will actually belongs to very high fracture risk. Or if you have a patient who developed fragility fracture while on osteoporosis treatment, or if they have multiple fractures, yeah, or they have fractures while they are on drugs causing skeletal harm, for example, high-dose glucocorticoids. Now, or they have high risk of fall, advanced age, and frailty. So I believe falls and frailty are probably will elaborate a little bit later. Yeah. And very high FRAX score. Remember, we need a FRAX of more than 20% MOF and more than 3% hip. You can actually diagnose osteoporosis. But if they are more than 30% MOF and more than 4.5 hip, they actually belong to very high FRAX score and they are under this category of very high fracture risk. Or the last one, if they have a T-score of worse than -3, yeah, they also belongs here. Then you might actually ask yourself, then many of patients of yours might belong to this very high fracture risk group. Yeah, possible. So, but this is the guidance in the guideline. This is how we stratify them. But let me bring you to frailty, because I think many of you who probably diagnose frailty through eyeballing, but there are actually assessment tools that we can use to assess frailty. Actually, there are many of them. Well, from what I know, there are more than 70 of assessment tools out there. But I will just bring you to some of the very commonly used. I'll probably bring you to two of them. Yeah. The whole point of the assessment tool is basically to assess, to determine the frailty level of that patient. But unfortunately, we don't have an ideal frailty assessment tool, because an ideal one, we actually are supposed to assess all these domains of frailty. But most of them, many of them are focused on physical frailty. Some of them focus on physical and cognitive, but none of them actually can measure all. But one of the frailty assessment tools that geriatrician we like to use is clinical frailty score, scale that is developed by Professor Kenneth Rockwood, Canada. To simplify for you, this CFS, basically you can categorize into 3 groups. 1 to 4, if they are completely independent. Yeah, independent in their basic ADL and instrumental ADL. So example of basic ADL are personal care, like dressing, showering, toileting, walking. But instrumental is ADL required of them to be able to function at the community level. For example of that will be driving, manage your finance, grocery shopping, do any housework, cooking. So those are instrumental ADL. So if an elderly are completely independent of that, they are not frail, CFS 1 to 4. Perhaps not so important for you to actually differentiate them between CFS 1 to 4, because they are all not considered as non-frail. And the next group will be mild frailty, where this group of people that actually need a bit of help in their instrumental ADL, that they can no longer drive by themselves. They can no longer go out and do grocery shopping by themselves. They are mildly frail, so CSF 5. 6, 7, 8, they are moderate to severely frail. So the moment they need help in their personal ADL, their basic ADL, they are moderate to severely frail. So just now in the previous slide that I mentioned just now, the frailty basically means if they belong to CFS 5 to 8. Another tool to assess frailty is your fit phenotype. Yeah, they actually look into this 5 domain. So if you have more than 3 domain measured positive, they are frail. Yeah, if there are only 1 or 2, you are pre-frail. If you have none of that, you are not frail. Yeah, this is another commonly used frailty assessment tool as well. So now bring you to fall-risk assessment. Why we think this is important? Because if someone who has osteoporosis keep falling, no matter how good your osteoporosis agent is or how good your treatment are, they will get a fracture. So I think it's important to identify the fall risk and try to do something about it. So if you remember this slide from Prof. Shamila last week, mentioned that the impact of fall, is actually very detrimental. We look at this busy table. It actually lists out some of the common risk factor of fall. But if you look at this, it's actually very difficult to remember all of them. So sometimes I do teach my officer that how to do a fall risk assessment by head to toe. I'll just try to bring you through this in less than 5 minutes. So we start from here. So if you have someone with recurrent fall, you want to know any cognitive impairment or dizziness can be the cause of fall. So if you have, then we have to find a way, is there something we can do about it? Then go down a level where you screen for vision and hearing impairment. And then cardiovascular, we look for anything that is cardiovascular cause of fall, usually aortic stenosis, overt heart failure, brady or tachyarrhythmia. And then urinary incontinence. And then we go down to look for musculoskeletal, which is sarcopenia and any joint abnormalities. The common joint that cause problem to elderly are knee OA, or sometimes they have ankle abnormality due to Charcot joint, uncontrolled diabetes. And then common neurological causes of fall will be Parkinson's disease, peripheral neuropathy, or pyramidal tract sign due to a stroke. So we do a neurological assessment as well. And then postural hypertension is common cause of fall, so we will do that as part of a fall assessment. Then we look at the footwear to see whether it's appropriate. And then on top of that, we will screen for environmental hazard. Do a medication review to look for any medication, we call it FRITS, fall risk increasing drugs, and any acute medical illness. So when you do it a systematically way from head to toe, most of the time you will pick up many risk factors. So the whole point of fall risk assessment is once you identify what are the fall risk factors, and then you check, are they reversible? You do something to mitigate the fall risk. So for example, cognitive impairment, if you find out patient has delirium, probably good news because delirium is curable. But if it's dementia, you can do something to slow down the decline. Visual impairment depends what's the cause. If you have a cataract, again, it's curable. But if you have a macular degenerative disease, then it's probably we acknowledge as a risk factor that is not very much modifiable. Sarcopenia, again, is very treatable. Postural hypertension, again, is very much modifiable, and Parkinson's disease as well. Then together, we do the osteoporosis assessment and treatment while reducing the fall risk. So of course, not all of you will have access to geriatrician, so you may also want to consider whether you can do some checklist-based kind of fall assessment and then manage whatever fall risk that you can detect and trying to reverse it. And then on top of that, refer to your physio for lower limb strengthening and balance training. And if you feel that you suspect some home hazard, you actually refer to your occupational therapist for home hazard assessment. So okay, so that is basically a brief introduction about frailty and fall. So in summary, basically, just now we talk about stratifying the risk to very high risk group. So any of this in the red box will be high risk group. Those in the orange box is high risk and the green in low risk. We've gone through that just now. So now the purpose of having the risk stratification is to guide your initial treatment. So if you think your patient belongs to the very high risk group, the recommendation is to start anabolic agent, or the alternative action includes your potent anti-resorptive, which is usually the injectable, like your denosumab and parenteral biphosphonate. If your patient do not have very high risk features, they just belong to the high risk group, which is osteoporosis group, then you can actually start with any bisphosphonate or even denosumab as an anti-resorptive. And then you reassess the fracture risk again every 3 years, every 1 to 3 years, depend on your resources. So this is some of the practical point that you want to think about before you think about osteoporosis. I won't dwell into too much detail of that because next week, I believe Prof. Jaya will bring you through all these treatment options and go into detail on each of these agents available. But in general, when we want to consider treatment, we have to think about the clinical profile of the patient. What is their preference? Whether they have any renal impairment. Yeah, if some of you may know bisphosphonate are contraindicated if your creatinine clearance is less than 30. Yeah, if they have any upper GI disease or if they are on nasogastric tube feeding, then your oral bisphosphonate will not be suitable. Then again, whether they are survival beyond 1 year is favorable, because the whole point of treating osteoporosis, right? You only see that treatment efficacy, which is fracture risk reduction after 1 year. So no point you think about it, if you have a patient that is 6-month prognosis is actually not favorable. So you actually, even though you start a treatment now, you don't see the treatment benefit from it. Yeah? So if your patient has a good survival beyond 1 year, perhaps you want to start osteoporosis treatment. And also you want to know your patient's cardiovascular risk, because some of the agents here are associated with cardiovascular adverse profile like romosozumab. So if your patient has significant cardiovascular risk, that may be an option that may be a concern that you want to think about. And even the route and dosing frequency actually may be a concern to some of the patient. So you have to see their preference, whether they prefer oral or parenteral agent. And then all these agents will have daily administration, where weekly, once a month, 6 monthly, or yearly. Yeah. So if your patient has polypharmacy and they have problem with compliance issue, so a regime that that is given 6 monthly or even yearly may actually be a better option in those scenarios. Yeah. And then lastly, of course, you have to look at the cost of the medicine and the resources that you have. Although when we do a risk stratification, many of your patients may fall into the category of very high fracture risk. Yeah, but we cannot deny that anabolics and the potent anti-resortive are costly. Not many patients can afford, and of course, not many centers, especially those who are working in the government setting, are able to give anabolic. Yeah. And also some note, probably some of you may be interested, is that romosozumab is not in the FUKKM yet, although they are in the process of getting FUKKM approval. It's estimated by probably end of this year or next year that it should be available in FUKKM. Another surprising fact is your zoledronic acid 5 mg for osteoporosis is actually not in the FUKKM formulary. Yeah, to my surprise as well. So these are some of the practical point for consideration after you achieve the diagnosis and also risk stratify before you finalize which agent you use. Because the treatment strategy, I will leave it to Prof. Jaya next week. So despite, you see, I think most of us here, we have some knowledge about osteoporosis, and you actually know once the diagnosis you need to treat. But despite all this fact, what happens in the real world is that the treatment rate for osteoporosis remains low. Yeah, it's not only in Malaysia, actually it is the same across worldwide that the treatment rate for osteoporosis is less than 50%. Yeah. So the problem here is there is a gap. Although there's a treatment gap here, although we know there's an indication and the benefit, but for some reason, this treatment is not being delivered effectively. And this is where I want to take this opportunity as well to introduce the concept of fracture liaison service, which we believe will be a bridge, the solution to this treatment gap. So the purpose of FLS is basically a systematic way that improve your case finding, because if you have a proper FLS, you will be able to capture all your fractures and provide them with evidence-based assessment, for example, your risk stratification, and then some of them will be investigated for secondary causes of osteoporosis, and then tailor suitable therapy for each of these patients. Yeah, and then one of the good things about FLS is also improve the compliance and adherence of therapy. So I apologize for some of these are not very clear, the font here you see. Basically, all the fractures that present to your center, they either will be captured through your emergency or through the X-ray. They will then be treated in the ward or in the outpatient clinic, usually it's orthopedic fracture clinic. So this patient in the FLS, in the proper FLS system, they will be notified to the FLS coordinator, which will then actually make sure all these patients get osteoporosis treatment, get a proper 4-week assessment, an exercise program, and education program, and making sure that they also come back and be compliant to all these things that's given to them. So that's the gist of the FLS. So I don't know if your center have FS, we can think about it. If your center don't have, and you are someone who are interested in osteoporosis management, I feel this is a system or program you can start. You can also think of building for your hospital or your clinic. Because this FIS, there is good data to support the effectiveness. Yeah, basically improve your BMT testing, improve your osteoporosis treatment rate and the compliance. And because of that, it will translate to a reduction of the refractures and the mortality. Okay, now, when we come back to our previous patient, the trade patient. So the first patient, the Mr. B, 81 years old with moderate dementia, moderately failed. If you remember the clinical failure score that I mentioned just now, he requires assistance in BADL, so he's CFS 6. He has high fall risk. Yeah, so actually he has many of these features of very high fracture risk. So from here, in fact, let's bring you through again. So the very high fracture risk features that he has is high fall risk, frailty, advanced age. But you look at the BMD score, it's not too bad, yeah, although it's osteoporotic, but didn't fulfill the very high fracture risk. But the hip fracture here is more than 4.5. So there are a few features here that makes this patient fall into the category of very high fracture risk. And therefore, in that algorithm, you're supposed to recommend them, if you look at our Malaysian guideline, recommend them either anabolic or the injectable or the required potent anti-resorptive. So we give this option. We had this discussion with the family, their preference, their choice, and also evaluating to the cost. For this patient, eventually they decided to put him on. We decided consensus between us, the physician, and the family. We decided to put him on denosumab 60 mg 6 monthly. Yeah. In fact, this is still actually the guideline is still belongs to still some of the guideline. We managed to practice a guideline kind of treatment here because this patient can afford. Yeah, and they didn't choose anabolic because they find it difficult to bring the patient monthly to the hospital. Therefore, 12 months before they choose, I think, which is a reasonable option. Whereas his wife, you think about how to re-stratify this lady. So in fact, from here, I don't see any features of very high fracture risk, yeah, from the clinical profile. But you look at the BMD, the T-score is actually worse than -3. All right, so there is one very high fracture risk features here. And in fact, the hip fracture here is also worse than 4.5. 4.5%. So with these two, actually, she also belongs to a very high fracture risk. So therefore, I discussed the same option again with her and her family, and this patient is do not have dementia, so she also participate in the decision-making process. So eventually, this patient decided to go for anabolic option, which is a romosozumab of 210 mg monthly for 12 months, and then sequence it, because after you start anabolic, both anabolic is definitive in terms of duration. So this option of romosozumab is only for 12 months. After that, you do have to sequence it with an anti-resorptive, and they have already decided that they want to choose denosumab to be the anti-resorptive agent after that. Yeah, the reason then I asked, and then you may ask, how come this husband and wife choose different things? Because this lady, the wife, actually is more mobile. So for her, she finds there's no problem for her to come for a monthly follow-up to have this injection done. So lastly, about the third patient who actually among them perhaps the highest risk because just had a recent fracture, hip fracture, and operated, rehabilitated. Yeah, so we had the same discussion with her as well because I believe by now you know that she belongs to very high fracture risk. Yeah? So we talk about this option again to her because whichever guideline that you use, actually these are the recommendations. Anabolic or potent anti-resorptive in the form of denosumab or zoledronic acid. So then she tell me, I will tell you after Sunday. So I wonder why after Sunday? Because yeah, her horse is going for a race. Yeah. So at the end of her race, so she came back and tell me next week, okay, doctor, I will choose denosumab, 6 monthly. Yeah, then we all know why. Yeah, because her horse didn't make it to the podium finish at the end of the race. So for cost effectiveness reasons, she chose denosumab. But any of these, in fact, any of these options would be good for her, yeah, because she belongs to the very high fracture risk. Any of these options is actually feasible for her. But her choice is that. Okay, so with that, I hope I've set you up nicely for next week, a systematic treatment approach of managing osteoporosis by Prof. Jaya. And before I end, I would like to invite some of you who might be interested in osteoporosis to attend the annual scientific meeting of the Malaysian Osteoporosis Society happening in October this year in PJ Avante Hotel. And again, another big congress that's coming our way, our regional congress, Asia Pacific PJ Fraction Network, yeah, which is actually happening next week, next month. Yeah, so those of you who are interested in who wants to know more about fracture liaison service, orthogeriatrics, or osteoporosis treatment, there's a lot of world experts that's coming to actually, they're going to be speakers in this upcoming congress. So hopefully you can join us for those who are interested. Okay, with that, I think I will stop here and thank you for your attention. So I'll pass the floor back to you, Terence.
Thank you so much, Gordon. Right, good job, yeah. Okay, excellent. Thank you so much, Gordon. I think that was a really great overview around the topic of fracture risks and bone health assessment, which quite nicely follows on from Prof. Shamila's talk last week and sets the scene lah for next week's talk by Prof. Jaya. So, to all of you, if you have any questions, please feel free to type them in the Q&A box or even the chat box if that is easier for you. So while we wait for people to type away, maybe I can get the ball rolling, Gordon, if it's all right.
Okay, sure. Yeah.
Um, so we always talk about the best treatment for fractures is to prevent the fracture from happening in the first place. So are there any particular groups of people that we should target fracture risk assessment, bone health assessment as a primary prevention intervention?
Yeah. So from a geriatrician point of view, all the clients that come to us, we actually do screen for 4 risks. So when they come to us, when you see the gait is abnormal, yeah, and they have multiple comorbids with polypharmacy, for example, more than 5 medicine. So you do know this kind of patient are at some sort of 4 risk. So you would like to screen them, yeah, but ideally put them into a 4 risk assessment to try to prevent the first injurious fall, yeah, for example. But sometimes it may not be practical in all settings because if you're in a high volume setting, so I wonder how that can be done. Yeah, but for us in geriatric, field of geriatric medicine, we do regularly screen for that. What do you think, Prof. Terence?
So falls and in older people, I do agree. Like if you fall, you're more likely to fracture as well. And we've seen how in the fracs calculation, the falls itself increases. Yeah, you're meant to up percentage lah. The fracture risk. But also thinking of colleagues who maybe look after younger people or more specialist cohorts like cancer, those who take steroids, those who may have endocrinopathies. I'm sure within those cohorts themselves, there must be people at high risk of developing osteoporosis and fractures that would require some element of screening. And I know the Malaysian Osteoporosis Society (CPG) would does describe certain cohorts that we should all think about. There's a question that's just popped up in the Q&A, and again, please keep them coming. There's a question along the lines of calcium. So you supplement osteoporosis patient with calcium, if yes, what dose? So maybe not just osteoporosis, maybe we can think of it bigger, if I may. I'm sure your patients would ask you this, Gordon. Should they take calcium? If you're a healthy person, should you take calcium? If you have osteoporosis, should you take calcium? Any thoughts from yourself about the role of calcium in bone health?
Yeah, I mean, if you talk about the osteoporosis first now. So if you have osteoporosis, your calcium intake requirement is recommended to be 1,200 mg. So it depends on whether your dietary intake can match that because it's probably not easy unless you are the one that takes a lot of dairy product. So if you were to give a supplement, if you have someone with osteoporosis, so you do usually give together with a calcium and vitamin D supplement. And the calcium supplement dose is usually 1,200 mg. So we normally give a calcium carbonate of 1 gram in total per day. So, and then we ask them to take some high calcium diet. So we give them a list of what are the calcium-rich diet. And vitamin D as well. So because together it makes a complete combo of osteoporosis treatment. So any form of vitamin D, we like the vitamin D3 of 800 to 1,000 units per day. Of course, the natural exposure of the sun will also give you some adequate dosing of vitamin D as well. So if people ask you for endorsement of vitamin D, you can tell them perhaps you go out in the morning sun 10 to 20 minutes a day. That would be adequate, not during noon, not during the very hot sun. Morning sun, evening sun, I think that would be the best time. Maybe you can add on as well. Yeah.
And what do you think about the healthy ones then? So those who are reasonably healthy say, "Oh gosh, should I take calcium to protect my bones?"
Actually, in the healthy one, there's also a recommended value. It's just that offhand I remember, is it around 800 mg? So you still have a recommended intake of calcium daily per day. If you again, it comes back to whether your normal dietary intake can match that level. If you can, there's actually no extra value of you taking any supplements, because we always try to think the natural intake is the best. But if that is not adequate, then sometimes you want to supplement it with like supplement pill or something.
Okay, thanks, Gordon. So I'll bring us back to the topic at hand today, like about assessment, risk assessment. In your cases, you obviously had the patient's BMD results. You were able to report their T scores, and if I work in a service or in a setting that I don't have access to DEXA scans, any advice from your side? How can then I make decisions about risk severity then? So yes, I know they have osteoporosis because they had a fragility fracture, but
Mhm.
how can I know how serious the osteoporosis is or how high the fracture risk is if I work in a place that doesn't have access to a DEXA scan?
So that will actually, our hometown Sabah is one of the places that I mentioned. In the whole Sabah, we probably have two DEXA. No, actually, including the private, we have a few in KK, but the other place outside KK, we can almost say there's none. So, but there's the osteoporosis people are everywhere. So for this group of people, we still can determine the risk assessment by number one, doing a FRAX. All right. But if you remember the slide, the features of very high fracture risk. In fact, you can see inside that whole list, T-score is only one of the features. There are many more. So if your FRAX assessment can tell you that your hip is more than 4.5% and MOF is more than 30%, or you have other features like very high fall risk, severe frailty, and those will actually put you into very high fracture risk group, even though you don't have a BMD. But the question is, without BMD, then how do you monitor the treatment response, I suppose? So in that sense, that's another challenge because in a way, you do want to measure your treatment chart. I probably Prof. Jaya will address this topic, or should we talk about it here? Maybe we wait for next week.
And so the question of treatment monitoring and how to go about and how you tweak your treatment accordingly lah, depending on responses and stuff. So yes, certainly that would be covered in the third session. So hopefully that again whets your appetite to join us next week for that particular discussion. Um, the uh question then about screening or at least assessment in the fallers. Are we saying that all fallers should have a DEXA scan, Gordon? Are you going as far as that, or just a FRAX you think should suffice?
Oh, yeah. Those fallers, in general, if you are falling, um, if you are, especially you are falling with other risk factor, more than 50 years old, with other risk factor osteoporosis, yes, that should be going for osteoporosis assessment. So if you have accessibility, you have access to BMD machine, by all means, you should go for a DEXA scan test. But if you do not have access to that, you still, I think you should, the physician should actually do a FRAX assessment or look for any asymptomatic vertebral fracture by doing just an X-ray of the lumbosacral spine. Yeah. so that we can come to a treatment threshold. So the whole point is we want to identify whether the patient has osteoporosis or fracture risk that has reached the treatment threshold equivalent to osteoporosis so that we can start treatment early. Because it takes more than 1 year in order to see the efficacy of fracture risk reduction.
Thanks, Gordon. I think that's really, really succinct. Um, they are so just a thought here, really. Um, there are n- there are a number of risk assessment tools out there. Although certainly Frax is the one that we all perhaps have heard of. It's the one that we do feature in our CPG as well. But what are the other assessment tools out there? Have you got much experience, Gordon, in utilizing them, and how useful are they?
Yeah, in fact, apart from facts, I'm aware there are a few more. In fact, the one that I've a bit more familiar is OSTA, that I think a primary care colleague will use a lot. I think that will again stratify into low risk, high risk, and then from there, from that point onward, you still need to either do a facts assessment or BMD score if your patient turned out to be high risk from the OSTA assessment. And the other equivalent to facts, yeah, I don't know if Terence can remind me of what there are a few, but because it's not regularly done in Malaysia, so that's why I'm not familiar. But I know there is some FREX equivalent assessment tool out there. Perhaps some other countries are using or some other guidelines are using it, but in Malaysia, not that common that I know of.
Yeah, I mean, certainly Frax is the one that with we do push on a lot more lah. I think it's ease of use, accessibility. It's quite widely adopted. Then obviously we can now risk stratify based on the Malaysian cohort. So there are many good things and about using Frax lah. And you're right lah. There are other tools out there. My take on it is I don't really care what tool you use as long as you use a particular tool to assess your fracture risk lah and your risk of osteoporosis. Because it shows that we're thinking about it, and hopefully that means we identify those at risk, and that would lead to treatment. Now, Gordon, this question is not going to go away, which is if you start osteoporosis treatment without BMD, how do we monitor them after treatment? So, although we said that this is probably something that Prof. Jaya will address in the third series, but maybe if I get you to reflect on your own practice, lah, um, or how you advise maybe some of your colleagues to reach out to you even from the district hospitals who don't have access to this. I mean, what's your
Yeah.
quick comments?
In fact, there are many centers in Sabah that is outside KK that do not have a BMD assess. So in those patients where we have sort of concluded this patient has osteoporosis equivalent because of history of hip or spine fracture, or we have done a FREX assessment on them, it has gone beyond 20 of MOF and more than 3% in hip, we decided to treat as osteoporosis. But now after that, we do not have a treatment sort of response monitoring mechanism. So what we do is that most of these patients are on oral bisphosphonate. There's a concern of risk of atypical femur fracture or ONJ after 5 years. Yeah. So again, although there's a so-called exponential increase in risk after 5 years, but then again, we balance it with the risk of major hip fracture or vertebral fracture. Perhaps, so maybe at 5 years, we will look at the overall situation again. So if this patient is very stable, continue to live on, so we're going to tell them this, after 5 years of alendronate, your risk of this atypical femur fracture and ONJ increases. So there are two ways to go about it. Now you have to travel somewhere to get the BMD done, number one. Number two, we actually change it to another type of anti-resorptive agent that is so-called less risk of atypical femur fracture or ONJ, like Prolia. So we get an option. If none of these are possible for them, and then their fall risk remains high, I will tell them perhaps the risk of you getting a hip fracture and the vertebral fracture is way higher than you having an atypical femur fracture risk. So we sort of have to come to consensus, both parties, the physician and the patient family, and we both agree. Then some of these patients we actually carry on with for some more than 5 years.
Yeah, I certainly echo that lah. I mean, the first thing is no one says it's easy to do treatment monitoring when you cannot monitor them. uh, with a bone density assessment. So the first thing is it is difficult, and I think most clinicians would recognize the challenge within that lah. But I think even sometimes without readily accessible DEXA, the clinical risk factors can also tell us a lot lah, about, at the very least, duration of treatment or duration of exposure to treatment, lah. Whether it's 2 years, 3 years, 5 years, or even 10 years. For instance, someone who has got uber high fracture risk, and all you have access to is oral alendronate, then it becomes a 10-year commitment to oral alendronate. So obviously not ideal, but I guess you still have to work within the setup that you're at and the resources that you have available to. But I think clinical risk factors can give you an idea lah. And if, let's say, during those years on treatment and then tiba-tiba that person develops more risk factors, diabetes, falls, frailty, someone gave them steroids for X amount of condition, and more risk factors start to develop, then again, lah, without a DEXA scan, I already know that this person A is committed to a longer duration, and, if available, more intense treatment lah, with parenterals and so forth. So yeah, it's working with what we've got lah. I think osteoporosis is still at that stage where we are still reliant on some element of BMD reading to guide decision making. Mm. Okay, so I am conscious of time, and I think I've put Gordon in the hot spot for a very long time already. What I might do at this stage is just to highlight again those two meetings that Gordon has flashed up. One is the Malaysian Osteoporosis Annual Scientific Meeting. It will be the 17th edition, happening this year. So it's been going for 17 years, which is great. Do look out for that in June next month. Actually, exactly a month from now, the Fragility Fracture Network will host its Asia Pacific Congress. So if you were to Google Fragility Fracture Network Asia Pacific Congress, it will come up. If you Google Malaysian Osteoporosis Society, ASM, I believe there is a flyer floating out in the ether lah. Gordon, before we end, any final words of wisdom that you want to leave our online delegates with? Any key principles, take-home messages?
Okay. Although this is mentioned last week, but I would like to just mention again, osteoporosis is very prevalent. It's probably as prevalent as diabetes. That's number one. Number two, if you do not have DEXA scan in your center, it's no longer an excuse not to screen and assess for osteoporosis, because we can do it with a FRAX assessment or by looking for any history of vertebral or hip fracture. So once you diagnose osteoporosis, try to do a risk stratification of what we go through just now in order to lead them to this ideal pathway of algorithm. Yeah, but I think with that, hopefully you can join next week and to know in depth on the available treatment strategies. And thank you, Terence, for hosting this.
Well, so it just leaves me with words of gratitude again to Gordon for taking the time out, to the College of Physicians for coordinating all of this and putting all together, and lastly and most importantly, to all the online delegates who have committed an hour of their uh, Tuesday afternoon to listening lah, about us talking about better bones for the patients that we look after. Now, I have been informed that CPD points will be given once you submit your feedback form. And if you have any questions in the flyer that you should have received advertising this, there will be contact details for the College of Physicians that you can reach out to. If you've not seen your CPD points accredited or you've not received your certificates, they will be the one that will coordinate that aspect. So again, thank you very much. Thank you all. Have a good day, and I look forward to seeing all of you at next week's webinar. Take care. Goodbye.
Thank you, everyone. Good day.